Hello, my name is Jeff Hauk from George Fox University, and I'm here to present the 50-50 lecture series where we discuss how performance and behavior change are 50% physical and 50% psychosocial. This is sponsored by the Beyond Biopsychosocial Learning platform at beyondbiopsychosocial.com. Dr. Reiger, you have a wealth of experience and skin in the game when it comes to connecting with patients. I mean, you are a clinical psychologist at SUNY Upstate, and you're head of the concussion and sports concussion program at Upstate. So help me understand your background a little bit, and then the people listening can kind of know who they're talking to.
Yeah, so I was trained as a clinical psychologist, but my area of expertise for the last 25 years has been acquired brain injury. So I'm the chief psychologist in the rehab department. So I'm in a rehabilitation department working right alongside therapists and rehab physicians. And my specialty has been acquired brain injury. So working as part of a team. And, I'm really sit in that space where you're dealing with people who are presenting because of an injury or illness, not because of them. They're not coming into you because of a mental health problem,
right?
A physical health problem. But the space we work in is the mental health or psychological issues that either accompany that injury, that are affecting the recovery.
So that's a great point. So these are people that are normal from a mental health standpoint that are recovering, but they need both the physical and the mental side of their kind of recovery to be addressed at some level.
Or they may have a mental health history, but that's not why they're coming in to see me. And the reason that's important is I've had a lot of experience walking that line with patients between wanting to validate their injury or their illness, even while recognizing that there could be a strong psychological component to what's bothering them.
Right. So they're not
whether those are physical or mental symptoms.
Right. And this is where we can get in. I think this is a perfect lead in to what I was hoping we would talk about today. So this is targeted at entry-level therapists. So we're trying to introduce these topics about what things they might want to learn. And so, new therapists learn a lot about rapport, and that's a very good thing, right? And typically it includes things like eye contact, a smile, a warm greeting, introducing themselves, things like that. But they're time pressed, as all medical providers are. There is no time. And so how they go deeper, they need, I think providers need motivation and understanding where the gain is. And so like, as an example, like a medical provider, might feel successful if they don't interrupt the patient for a whole minute, right? Because the typical medical provider starts the interruptions in less than a minute. And that includes physical therapists too, right? Because they're time pressed to get to the, cut to the chase and start the treatments. So one of the things that is a question is like, how do you balance rapport with knowing more about the person to make it worthwhile? Like, how do you use the information and how do you kind of try to, understand their identity or something more than just this kind of superficial rapport to kind of help you plan your treatment to make it really worthwhile? Like, where do you go in your conversation with them?
So you really can't do the work we do if you're not able to connect with patients. So I would say that just really being able to tune in and listen to patients, it sounds like you're going to say that, like that's an important skill, but what that really means is a little more difficult, but it's so critical. So for example, one of the things, we have a phrase that we say for psychologists, follow the feeling.
Oh, interesting.
So if there was one thing I would have you guys try when you're observing interactions with clients is turn off the content for a minute and ask yourself, what's the feeling? Because if a patient comes in and they say, yeah, I've got pain in my foot and I've been to my primary and I've been to the orthopedist and I don't know, they just told me to come in and see you.
So you're frustrated.
So
Yeah.
as a therapist, you could say, okay, so you're here to treat the pain in your foot. But you have just missed, if you say that as your
Yeah.
response, you
Right.
have missed a huge opportunity. Saying, and it's a little counterintuitive to amplify those emotions that you're going, okay, I got to get through this visit, and this patient's worked up, man. It's
Yeah.
counterintuitive to want to stop and say, wow, you are frustrated.
Yeah.
Like you've got pain in your foot and nobody's been able, are they not helping you? Are they just not listening to you?
Right. So you kind of, so you amplify it so that then they tell you more, and then they start to feel safe with you or connected.
It actually takes when they're not going to hear you or work with you when that emotion is there. And until you acknowledge it, they're not going to get past it, and they're not going to be hearing you.
So this is where the time comes in, because you're in a hurry to be a PT and you're trying to get to your physical treatment, and right there you didn't catch it. And so by taking another 3 minutes or 4 minutes or even 5 minutes, just to make sure that you're both on the same page and that you're validating what they're experiencing, may make all the difference in their actually doing or listening to what you're trying to do with them.
Well, and ultimately what you want is for the patient to be clear about what they're looking for and what they need. And so when you say you're really frustrated, they say, yeah, I'm frustrated. Thank you. Right.
Yeah,
so now right there, when you get like an exactly or thank you, then you know you're kind of in the room with them. And then you can say, well, geez, are you concerned that I'm not going to be able to help you either? Like I would actually go right at that.
Well, you would maybe just lay it out there.
Oh yeah, because otherwise it's just going to be there.
So you're
go right at that, and the patient might even say, no, I think you can help me. All right, well, what is it that? And you've just done a little motivational interview kind of trick there. Does that make sense?
Yeah, totally. So you're not really thinking about what your needs are. You're just trying to say, okay, what I'm hearing is frustration. And then the possibility is, I mean, I could even be seen as like, they're not even want to be here really. And so I better check in with that. And just as a possibility, right? And by doing that, there's some trust built, because it's like, you're being authentic. Like, hey, if you don't want to be here, let me know. Right. And so that's starting to get this idea.
And now they own the session. They own the session. You don't own the session. You want them to own the session.
Right. And what about
the set?
Yeah, I like this because this is the shared decision making, or putting them in charge, or their empowerment, right? So this is where we get into these ideas of engagement, and I kind of want to stay on this idea of why this is important, like where identity or where rapport like kind of ends and this second piece kind of begins, right? Because it's like this deeper part, right? And so because we can kind of get into these other topics, I think, on a separate video, but for this one, to spend time in like the example you gave is kind of interesting, because they had an emotional reaction, so you follow the feeling. But what if you don't feel like you're really getting at what somebody's motivations and drive is, and how do you, because they have these physical problems, because we're going to measure them and they're talking about them, right? But how do you get into the deeper part of like getting them to expose like, what their real kind of thinking is, or cognitive processes related to how they're healing on their sense of self? Do you know what I mean? And I'm not even sure what that means, but how do you address that non-physical part, basically?
Right. And I think, in terms of understanding a sense of self, that's not a 1 or 2 minute. That's something that will, so I guess the point is, I don't think you do that in the first 5 minutes and now you do your PT. I think that's an ongoing engagement where you're checking in with the patient multiple times.
Well,
and I think also, but to start, I love these kinds of questions when you start a visit with a patient. So what's your understanding about why you're here today?
So that's a longer, but that I think providers might be afraid to ask because that can go it's an open-ended question. It could go any direction, right? And it may take some time, and they're going to need to follow it up to kind of, contain where exactly it goes at some level, even though it contains kind of an interesting word, but they want to keep it focused on the healthcare component at times, right? So they're worried about time right there when you do that question. So how do you like navigate that part of it? Because for you, you're the same situation. They could go off on a lot of different tangents with that opening.
Right. Well, I think if someone starts to go off on a tangent that's sort of not really relevant, you do have to manage that.
Yeah.
What you want to know is you want to understand the internal world of that patient. What's their model for what's going on with them and why they're here? What is this about? Is this about you're the only one who can fix me because they can't do surgery? Or is it about, you know what? I've had this pain. People have been telling me for years I should go to therapy, and I'm finally here because I can't. I love to walk and I can't walk anymore. Right. Or I'm here because my mother told me that I have to come to this, or else I can't play hockey anymore.
Because that's the concussion. The young.
And then you want to know. Then you want to know that, right? You want to go.
Right.
Well. So where are we going with that? Like I would just again.
Right, because that's a great example, because then you're just going to end up talking, well, how can we make your mom happy? You're not directing it at them, right? Because that's their motivation, right? So I guess what you're helping us understand is like once you get the rapport started, it doesn't really end there. It's like these questions have to come from like a deeper place. So you say, well, why are you here? But it sounds like, based on the first example, like they don't usually, I'll ask you, do they usually give it all up? You say, oh, hey, why are you here? And then they just spill everything, or what do you have to do to like get that underlying reason? Because it seems to me like most of the people aren't going to tell you right away, oh, it's because my mom told me to come.
No, and even an open-ended question can make people a little anxious, right?
Yeah.
But again, it's a little bit, think about it, you're not used to that in our medical system, to
right.
being put in a position where you need to articulate to a very open-ended question, not just what's bothering you, but what's your understanding about why you're here today? Those are different questions. And so I think some people will not go anywhere with that, and then you have to sort of work on that. But you really want, I guess what I'm trying to say, Deb, is that you want to know, are they here reluctantly? Are they here because they have a very specific thing they want to accomplish that they can't do? Are they here because of pain, or are they here because they can't bicycle? Well, and you want to be able to, what's the first thing that comes out of their mouth? Those early statements can be very revealing.
Right.
Before you're in the nitty gritty.
So for you, this part of it is worth spending time on, because it's going to lead to action, and it's going to lead to action that's not your action but theirs.
And I think also that the success of the therapeutic endeavor requires that the patient trusts you, feels that you hear them, and that you have agreed upon what we're working on. And just working on creating that feeling, whatever the goal is, if that's how the patient feels, then they're going to do the work.
Right. Or you're going to understand.
You can have a different idea in your head about what they need, but that's okay. You know what I mean?
Right.
You don't have to, but you have to have them feeling like you're in here to work on what they want and you get it.
So this is good, right? But how easy is this to get like at these kind of deeper like reasons for them coming in?
Well, we spend a lot of time in training on just this whole idea of empathic listening. Active listening is a difficult skill. And that's where it starts. And then I think, I don't know. I guess for some people, it's easy.
Mm-hmm.
Others, there's not going to be a lot of emotion there. And if there's not a lot of emotion, there's probably not a lot of engagement.
So when you're trying to follow the feeling, you're not picking that up. And then the second piece is the listening piece, this active listening part. Like if you haven't really invested time in those skills, or they're not coming naturally to you, whatever that is, then you're really going to miss these what's really happening, why they're really in the room with you.
I mean, as a psychologist, when emotion comes up, it's like the pearls we're diving for when you find one. And so you're going to amplify, and that's what we mean by follow the feeling. So even during the session, Jeff, I think if someone goes to do something and then they're exasperated or frustrated or whatever feeling comes up, like to me, those are moments to pause, amplify that feeling and see what's associated with it. Not because your job is to be a psychologist.
Right. You're just
because your job is to connect to the patient and feel like you're in there working on what they want to work on.
Well,
otherwise you're not going to work on it.
Right. And the things we're asking them to do, I'm just remembering like some of the cases I've had with people that had multi-morbidity, like, different fractures, a talus fracture and a, shoulder from a bicycle accident or something like that. And the degree of difficulty, like, is very high in like recovering muscle function from like a 6-month, immobilization or a, kind of a Ilizarov, kind of approach where they're, remodeling your bone and these different kinds of things. It can be significant work to try to get through that, to get your physical body back. So if you're not really understanding what their motivations are, what's driving what they're experiencing at the moment, they're disappointed or, they thought it'd be easier, how to adjust or understand what kind of challenge that they want at that moment. Right. And that's where the physical and the psychology come together. Right. Because that's where knowing a little bit more about their identity or what they're experiencing or the feelings they're having can really help you, because, not overdose or underdose your patient, making sure you're hitting, them and helping them understand that, what they have to go through, that they have a partner in you that's not just, kind of, throwing physical things at them.
Correct. And I think even again, asking questions like, so what has anyone told you about what you can expect in terms of improvement or recovery? You want to know where they're at. Like, are they thinking, well, my doctor told me that if I come to see you, I'm going to be good. I can do whatever I want. Well,
right.
How long did they tell you that was going to take? You kind of want to know up front so that you can address if there's a mismatch, like, okay, I've been you twice, I'm not better. What's going on? Like they may not be saying that, but if that's what they're thinking and you don't know it.
Yeah, because I bet people don't even know, we talk about physical therapy and how people don't know why they're there, except they know they're going to get some exercises or something. But I bet for you, it's even more dramatic. Like they just think they're going to get talked to or, and they don't really know what good that's going to do them. So this question must like evoke all kinds of different reactions from patients for you.
Yeah, I was just saying that you're even asking these questions. What you're doing is you're making sure the patient is feeling that the framework for this relationship is we need to understand where each other's at and we're working together. Not I'm coming to the doctor to have a couple bolts tightened.
Right. Yeah.
And then I'm going to go out and I'm good to go. That's not how we roll. That's not how you guys roll. That's not how we roll. Right.
Right. But it is. So this is good. So this is. I think this is good. So I was going to end here. Just keep it kind of short, right? But like, do you have any parting shots? Like, like this idea of getting like to me, what I've heard you say is you have to use direct questions open-ended questions but you might have to follow it with something direct too. Like, so you have to have, some skills in active listening so you can kind of keep those questions coming, and then the time to kind of take in what the patient's saying. And then you might not all get it on the first swipe. Like you may have to, it may take, a session or two, or you may get it at the end of the session as you're kind of continuing with different experiences and things like that you really start to understand what the patient's really driving at.
Yeah, and I think, we take vitals when people come in. We should be taking people's emotional temperature at the start of the visit.
Yeah.
And we should be placing them on the chart in terms of what their expectations are. Those should be data points that we're gathering. And the way we're going to get someone's emotional temperature is by listening to them. That's how we get that. We don't have a thermometer for that.
Right.
So if you don't have active listening skills, you don't have the ability to gather that data and then factor it into your treatment plan and the way you're choosing to work with this patient.
Yeah. Well, that's good. So it's essential you have active listening skills. It's essential that you start to develop this idea of following the feeling. And then I think that's probably enough for this part. And then, anything else?
No, and I think just to realize your job is not to make them feel better. That's a very important thing. Don't try to reassure them or give them idle sort of comfort emotionally, because good listening sometimes is exactly the opposite. Wow, you really are sad that you're not able to do all the things that you used to be able to do.
And that's really
that's not what my wife, the PT, is going to say to a patient naturally, because she's physical and we're going to get you to be able to do what you can do. We're going to cheerlead you on. And sometimes it's the exact opposite that's actually engagement building.
And I forgot that your wife is a very good therapist that's very into Pilates and things like this. And so,
right.
But so this is something that I've kind of struggled with too, because I see the therapists, they love cheerleading, and they love it. And they actually, a lot of people believe that is an essential, kind of psychosocial thing to do. But you're kind of agreeing, something I've come around to as I've looked at the psychosocial stuff too, is it's really not effective and can be very negative. Patients can get very angry inside and just don't share it with you, because they think you're very superficial and you don't really want to know what's happening with them. Right?
Correct. And it's not empathy.
Right.
Accurate empathy is reflecting the feeling that you hear.
So this is a great way.
Modeling your tone and your behavior so that the patient feels like you're in the room. And then that will actually help them set the emotion aside and be present in the session with you more than cheerleading by far.
Right. And so and what they'll be able to get out of their patients, because they're connecting exactly with how they're feeling, is probably going to be better. And that's where we need more research. But I think that's the place to go, is for motivation and identifying goals and these other things that'll come. There's other techniques later for those discussions, but this important part of setting aside time at, somewhere in that first session to kind of try to get beneath those layers as far as you can, because there's a lot of good treatment decisions are going to come from that basic engagement of the patient, right?
Don't be afraid of the emotion. Go into it.
Yeah. All right. Well, Brian, that's it. That's what I was hoping for. So tomorrow, so I'll turn this off. So I'll stop recording.
Yeah.